I got an interesting topic, which after doing this for 20 years, you kind of wonder about these things when exactly how much radiation have I gotten over the years. So um, it's a topic that affects all of us, though we don't often think about it consciously, I think, because we're sort of inured to this idea that, we're going to have flow around and there's going to be zappage occurring in our cases. And especially, being in a teaching program, uh, like sometimes the amount of fluoro being used is kind of uh, scary, I guess is the way to put it. But some thoughts on my part about reducing X-ray exposure, and some of this, we should all know because we should all be taking our compliance classes on radiation safety. So realistically, I think it starts before you get in the OR. This is about protecting you and the staff. And where it starts is having your appropriate preoperative exams and having them readily available so that you're minimizing your guesswork in the OR and you're minimizing your surprises. Because if you want something that's going to rapidly increase the amount of X-ray and fluoro you're going to be having in the OR, it's something unexpected. And that usually happens when, you're not adequately prepared. So that bottom one, no surprises. I mean, none of us like surprises in the OR, right? None of us do. They're never good. And so getting the right workup, getting the right preoperative exams, this is, where you start with reducing your radiation exposure in the OR in particular. So classic situation is a hardware removal, right? Did I get all the screws? Where are they? If you got your x-rays there, you don't have to guess. Now, for a lot of us, especially if you work at a single institution, this isn't such a big deal because it's in your PAC system and you can have your PACS x-rays put up. But so for instance, I've started because of COVID pressures and whatnot, operating at a surgery center a lot, which is not connected to our institution. So if I don't have the x-rays, then some guesswork occurs and flow starts happening. And if you think your C-arm techs are dead at your primary institution, wait till you go to some random surgery center and see how lively your C-arm tech is there. So this was a case, guy with a distal tibia non-union. He hated his medial plate, not surprisingly, that most of the patients do, want his medial plate out. So, doesn't seem like it'd be a big deal. Everything seems in continuity, but I didn't have my x-rays there. And guess what? I forgot those two screws because they aren't part of the plate. So surprise, that wasn't good. And we had to actually take them back and get those out and some fluoro exposure to go find those, etc. So CT scans preoperatively, incredibly useful, but lots of radiation. The cancer risk is real. In some of the Central European countries in particular, where people get CT scanned, trauma patients get CT scanned like CTs are going out of style. They have actually documented increased cancer rates in this patient population. They just think the trade-off between missed injuries and later cancers is worth it. I'm not so sure about that personally. So my personal opinion is use them judiciously, but they are incredibly useful. And if you want to talk about studies that will help reduce your surprises in the OR, is appropriate CT scanning in particular. So basic fluoroscopy exposure rules. If you're not wearing a wraparound type protection, always be facing the image or facing where you're going to get the scatter from. Beware scatter. That's actually where our primary exposure comes from. Protect your eyes. That's something I probably didn't do adequately for the first at least 10 years of my practice. I try to wear some sort of eye protection or keep myself far away from the image now, but protect your eyes. And remember, distance is king. It's all about being away from the image. The inverse squared rules apply to distance. So scatter, where does the scatter come from? It actually comes from two areas, but mostly the patient. So as the beam hits the patient, the particles bounce off the patient and hit you. And this actually gets worse as we get our biscuit poisoned patients, right? Because you need more X-ray to penetrate. Well, that more X-ray actually also means more scatter. So keep that in mind. Try to keep you and your staff body parts away from the emitter and the patient actually when you're zapping them, and it'll decrease your exposure. Shielding, how important is it? It's actually incredibly important. Aprons reduce your torso exposure by approximately 95%, thyroid shields by 97%. So they actually really do work. Please use them. Again, I didn't use a thyroid shield when I was a resident. Granted, we didn't have as much fluoro back then either, but and I only started using one as an attending probably maybe 7 or 8 years into my career because I didn't understand this. But I don't have any thyroid problems, I don't think. Not that I know of. Maybe I should get that tested. I don't know. But use your shielding. And again, it only works if the shield is between you and the radiation source or scatter source. So if you're not using wraparound protection, face the emitters and face the patients. With appropriate shielding, at 3 feet, you only get 0.1% of the exposure, and at 6 feet, really it's minuscule. So the 6 feet rule is actually real. Like once you're 6 feet and more, you're probably pretty safe. So then this is why distance is king, and staying away from the scatter sources and the emitter is important. Magnification. Oh, magnification. Don't do it. You're much better off playing around with the height and distance of the collimator to the patient to get your zoom. The way the C-arms create magnification is they jack the output of the emitter way up. So please don't do it. Don't let your residents do it. It's a bad habit. Get them to move the base plate in and out to get their zoom if they need to zoom for freehand distal interlocking and whatnot. Don't hit that mag button. It's greatly increases the output of radiation. And finally, as we get a little more high-tech options, people talking about using 3D imaging in the OR. Again, be judicious. The O-arm in particular is basically like setting off a nuclear bomb inside your operating room. That's why everyone like runs away and leaves a room when the OR goes off. But bear in mind, your patient can't do that. So be a little bit judicious there. And again, the 3D imaging things like the Zeem and the new OEC 3D CFD, that they are much better than the O-arm because they're not actual CT scans. But it's still a lot more image, right, than just taking flat shots. So kind of use your imaging judiciously. And I think that's all I have. Any comments from anybody?
There is a question in the Q&A if you can pull that up.
What are your thoughts on shielding with mini C-arm usage? So just me, I can't stand mini C-arms. So I'm probably not the best person to ask. The thing's always kind of bobbing in and out, and it's hard for me to get steady shots, and they just drive me nuts. And I know what you're talking about. They say that supposedly the radiation emission is so low that you can like not wear shielding, but I mean the thing's like literally in your lap and in your face when you're using it. So it kind of scares me to not have protection using these things. I mean, I know what the literature says, but it's worrisome to me. And again, I'm not the best person to ask to anyway, because I just hate how they're not steady and they always kind of bobble around. And so I detest using mini C-arms personally. So I'm probably not the best person. Anybody in the panel have a lot of experience with them? Because like I said, I hate them.
I also hate them. Chuck, and anecdotally, one of my mentors when I was a resident was a hand surgeon who died of adrenal cancer and was, using unshielded mini C-arms. So I don't know that that's related, but just terrified me. So,
Doc, that was a really good talk. I have a couple comments on C-arm. When I was a resident, I spent 2 months in Russia at the center of Ilizarov, and they didn't have fluoro there. And I think that really helped me a lot early in my training to do lots of cases without fluoro. And the way they do it is they take an X-ray in the operating room with skinny wires just poked through the skin as landmarks. And then they would hang that on the X-ray box. So they would feel the bones with their hands and look with their eyes at where the metal parts are, and then reference that to where the bones were. And man, they were freaking good. Like, they could find stuff without fluoro. And so it always freaks me out when people have an open wound and they reduce a fracture, put clamps on it, and then they check an AP and a lateral. Why? You're looking right at it. Like, you're looking at the bone. I don't understand why people will fluoro that. So I think it's a habitual thing, and you can train yourself to take lots of less fluoro shots. So I try really, really hard. Like, sometimes when I come in the room, I tell everybody, we're going to do 5 fluoro shots for this whole case. Mark my words. And we try to do the whole reduction and put in a couple screws and things like that. Then check an X-ray at the end, an AP and a lateral. If one screw is long, change it. If your reduction is off, fix it or whatever. But most things, you're looking right at them and you can tell if you've got the reduction correct. I mean, obviously, if you're doing some crazy ass tabulum or a pilon, I get it. But most things, you don't need to take a million fluoro shots to see what's going on, but it becomes a habit, I think. So if you start with the mindset that we're not going to do a lot of fluoro shots, we're going to do this all just visually, after a while, you realize you're less dependent on it and you don't need it.
Yeah, I think that's one of the conflicts we suffer in teaching programs, because they kind of want to document everything. They want to say, look what we did, so you can go to your fracture conference and kind of show this and show that. And I get it, and absolutely, it's great for teaching purposes. But kind of the issue is it becomes cumulative exposure, right? Like, once you've gotten that dosage, it doesn't like ever go away in your life, right? It sticks with you. And so, I think about like I said, when I was a resident, we didn't have easy access to fluoroscopy. So, we do an ankle fracture, and how would we check the ankle fracture? We'd take a couple hard plates at the end. And if there was something wrong, we'd change everything at that point. But, and, I greatly admit, having fluoro shots along the way kind of obviates that and makes it easier, faster, whatever. But, it also, like you said, makes you high. It creates this habit of taking shots all the time, and it's the balance, right? And probably, and it's hard with residents too, because they're also in the sort of relative, Superman phase of their life, right? Like, nothing can touch them. So
you guys make excellent points, and I think the key that all of you are making is the habit, and that the opportunity for us to be aware then of what our habits have put us at risk for, and then to start to improving. And just that awareness, you did a great job of that.